So welcome to your last session. My name is Abby Hunt. I'm the CEO at Healthcare Education and Training. I'm so happy to be here with you. I am going to introduce you to your final speaker today, Cara Berg Raunick. She's a nurse practitioner. She's our Director of Health Strategy and Advancement at HCET, so we're so lucky. Her work with HCET focuses on improving reproductive and sexual health and adolescent health outcomes throughout the Midwest, and she also serves as our director of the Midwest Trauma-Informed Care Training Center, which is a project of HCET where we're working to train clinicians across the Midwest in trauma-informed care. Cara's worked in women's health and family planning throughout her career. She has a clinical practice through Path for You, which is Indiana's free contraceptive access project. Using and advocating a trauma-informed approach has been central to her philosophy of care since early in her career, where she worked as a certified sexual nurse examiner at the Cleveland Clinic. She's past president of the Indiana chapter of the International Association of Forensic Nurses and serves as the lead for the Indiana Perinatal Quality Improvement Collaborative's Trauma-Informed Care Subcommittee. She teaches frequently in community, academic, and professional settings on all of the sexual health and trauma-informed care topics. So welcome, Cara, and I'll turn it to you.
You're welcome. Okay. Hi, friends. Can everyone hear me okay? And can most of you see most of my face above the computer? Okay, great. Thanks for sticking with the day. I know it's only been a half day, but I know conference days are long, so I appreciate that you're all here instead of hanging out outside. Cool. Also, someone yell at me if I talk too fast because I tend to get really animated and excited and can roll really quickly. And what else do I want to tell you? And I tend to roll pretty casually, so please, if you have questions and want to interrupt, that's fine, but also we'll have Q&A at the end. And then the last thing to let you know is we're doing a really fun tandem click dance. So Jen is advancing my slides for you, and I'm advancing my slides for me, and so bear with us if things get ugly in the middle, but we're going to do the best we can. Cool. Okay. So friends, I really am honored and humbled to be with you. I want to level set with that I know that in this room, there's probably a wide range of knowledge on trauma-informed care. Some of you probably are sitting here saying what is that? I haven't heard of it. And some of you may be like, I could teach this myself. I don't know why I'm sitting here listening to this. So my goal is going to be that we are going to develop kind of a shared language and framework at the beginning. So we'll kind of bring everyone along, and then we'll hopefully go places in terms of application and other things that even those of you who feel super confident in your practice in this area may have some new things. I also know that there's a big range of professional roles in here. And so some examples may be more directly applicable to some of you or others of you. Again, my perspective is that of a clinician. But again, I'll try to aim broadly, and hopefully there will be something valuable for everyone. Cool. So no conflict of interest. And, Abby mentioned the Midwest Trauma-Informed Training Center, and just wanted to share, if you haven't heard of us yet, that MTITC is a program of HCET. And what's up on the screen is our kind of North Star, or our goal, which is really to transform the landscape of health and human services by providing tools so that trauma-informed care can be standard practice, right? That can really be the standard for all. There will be a QR code at the end of the talk so that you can sign up for our emails or updates and so on. Also, I love all this stuff so very much. So please don't hesitate to ask me questions or reach out. My contact information is also at the end. So we have some objectives here. And before we go any further, as you're perusing this, I just also want to mention that talking about trauma and trauma-informed care can be very difficult. There's, as we'll see, there's no world in which there are people in this room who are unaffected by trauma, right? So if you need to do anything to take care of yourself, if you need a pause, I always prefer to not watch people hanging out on their phones a lot, because then I get insecure. But if you need to zone out and hang on your phone, do what you need to do to take care of yourself during this time. Okay, cool. So we're going to jump right in to learn about what trauma is, because we can't really understand trauma-informed care without that sort of shared understanding. So, trauma can be defined in many ways. One definition that I really like is the idea that it's something that overwhelms a person's ability to cope. The DSM provides another that is actually really quite a narrow definition. And then the definition that I would say is kind of the best established and that we're going to really use to ground us today comes from SAMHSA, the Substance Abuse and Mental Health Services Administration, who defines it as something that results from an event or set of circumstances that is experienced by an individual as physically or emotionally harmful or life-threatening, and that has lasting effects on the individual's functioning and well-being. Now, that threat can be real or perceived, and exposure to trauma can be direct and personal. It can be witnessing trauma to others, or indirect exposure through the traumatic experiences of a family member or loved one. Um, and one thing that you'll notice here is the bolded 3 E's. So, kind of 3 key components: events, experience, and effects. So, when we look at those 3 E's, experience, if we go to the next slide, Jen, thank you so much. When we look at those 3 E's, experience is key. So it is the individual who decides if a given experience is traumatic or not. And the same event can actually be experienced by one person as traumatic and not at all traumatic by another. So one example in my OBGYN world would be the experience of a C-section, right? You can imagine for one patient, it's just one of 2 ways a baby comes out, right? Maybe preferred or not preferred, but like either way is okay. Healthy parent, healthy baby, not a big deal. Maybe for another person, this is really their delivery of choice, right? This is the like empowered, self-contained method, right? Where they can make sure that their sister flies in and they know their last day of work and it's really the best possible outcome, right? And then you can imagine that for still another person, this could be one of the most traumatically impactful events of their lives, right? Really perceived as a failure of their body or their womanhood or whatever else, right? Um, and if that's happening, you can imagine now that that person might be reminded of that trauma every time that they look at themselves in the mirror or every time that they go seek healthcare, especially GYN healthcare, right? Now, another example could be the experience of a new diagnosis of HIV, right? Perhaps one person is aware of the existence of treatment options, understands U equals U, and knows people in the community that have lived robust and long lives with HIV. So while it means new medical care and maybe was not desired, they know how to manage it. They have they know how to cope, right? They feel supported, and it's not truly traumatic for that person. And then we even hear stories about people who experience relief, right? Because now they know they can take steps to manage it and not live in fear or anxiety or that space of not knowing. Whereas for others, we have all likely seen someone for whom the diagnosis was truly devastating and a true trauma, right? We can see that same experience or same event that is experienced differently across different humans. So, types of trauma can be broken down further into additional categories. So, some trauma is acute, and this is something like a one time event, like a natural disaster or a one time sexual assault, often the things that people think of as kind of big T trauma, right? Some is chronic. Or complex, like witnessing or experiencing domestic violence, living with or loving someone with a substance use disorder, experiencing human trafficking, or living unhoused. Now, traumatic experiences can primarily affect one individual and perhaps extend out to his or her family, like think about a car accident or a sexual or physical assault or a severe illness within the family, right? It can also exist within the context of a group. So we could think about trauma experienced by first responders or those who have seen military combat or in a community as a whole. So we could think about gang-related shootings, right? It could also transpire within a certain culture. So a mass shooting at a synagogue or a queer bar, or as a large-scale disaster like a hurricane or a terrorist attack, right? So lots of different sort of components of trauma that we can think about. I also want to spend a few moments on historical trauma. Now, historical trauma reflects systemic oppression of a particular group across generations. I myself am a grandchild of Holocaust survivors, so we certainly feel this within my own family. All right. Dear clicks, please work for me also. All right, awesome. Our patients and clients are often bringing this well-earned mistrust that's historical in nature, this mistrust of the healthcare system into our interactions with them. This is especially true in our world of sexual and reproductive health, right? In gynecology, we have specific examples of historical trauma, such as J. Marion Sims, who was considered the father of gynecology and even had the statue erected of him in New York City. It has since been removed. Sims invented the speculum and developed surgical techniques that are still used today and helpful in modern medicine, but he did this by experimenting on enslaved Black women. You may have seen this painting before. This shows Dr. Sims and Anarcha, who is an enslaved woman who was just 17 years old when she had her first baby. And Dr. Sims performed 30 non-consensual surgeries on her. He did not use anesthesia, even though it had recently become available. And at the time, people believed that Black women did not feel as much pain as white women did. And in fact, that myth persists today. It is well documented in the literature that Black people receive statistically less pain medication than white people during hospitalizations and after surgery. This legacy of historical and intergenerational trauma continues in our society with truly more examples than we can count. So from Henrietta Lacks, who was a Black woman who in 1951 had cells taken during cervical cancer treatment without her knowledge or consent for use in medical research or compensation, or the history of the pill, where clinical trials were done in the 1950s on Puerto Rican women without being told that they were in a trial or about any of the potential risks involved. To our country's history of coerced and involuntary sterilization, to Tuskegee, which is perhaps the most commonly thought of example when we talk about historical medical trauma. And this is where Black men were followed for 40 years from 1932 to 1972 to see the progression of syphilis. And this was done without their consent and well after the treatment for syphilis was available. And friends, 1972 truly isn't that long ago, right? We know that we are seeing patients and clients who either perhaps lived through some of this themselves or may have grown up with their parents talking about some of this, okay? So all of this has sown distrust in our systems, and systems level trauma and historical trauma absolutely enters our encounters every day in healthcare and in life. So we've talked about experience and events. Is everyone doing okay, by the way? Yes. Okay, great. Yay. All right. And I hope my Zoom folks are too. All right. So we've talked about experiences and events. Now we're going to talk about effects. Hopefully, many of you have heard of the ACEs study. If you haven't, this is your official invitation to learn more. So in 1998, Kaiser Permanente, in partnership with the CDC, did a landmark study with an N of over 17,000 participants that looked at 10 categories of adverse childhood experiences, or ACEs, and found that living through these 10 types of adverse childhood experiences can lead to or increase the likelihood of multiple types of adverse health outcomes. What they found was really a dose-response relationship. So they didn't look at severity or frequency, just like plus minus, has this happened or not? And what they found is that the more ACEs a child experienced, the more likely they were to experience these negative outcomes. Now, an important note about this study is that the participants in this study were largely white, largely middle class, and highly educated. A more recent Philadelphia ACE study focused on a more diverse and more urban population, and it focused on community level adversity and how that could impact health outcomes, and ultimately found these additional 5 ACEs that are noted here in the dark blue circles. So those include living in foster care, feeling discriminated against, experiencing bullying, witnessing violence, and adverse neighborhood experiences. So we know that ACEs are incredibly common. From the original 10, 64% of people have at least one ACE, and 17% have 4 or more. Now, I also want to be very, very clear that experiencing ACEs or other trauma does not mean absolutely that bad outcomes will happen, right? People are resilient and are buoyed by supportive and nurturing relationships and more. That truly could be a whole talk on its own. But ultimately, I just want to leave that the higher one's ACE score, the more likely these poor outcomes may occur, but it is not a foregone conclusion. Okay. So now we're going to look more closely at what those effects are. What can trauma do to our health? So again, the more ACEs a person experiences, the more likely they are to have any of these negative health outcomes. So for example, we know that people who have experienced 4 or more ACEs are 12 times more likely to have attempted suicide. They are 7 times more likely to abuse alcohol and 10 times more likely to have injected street drugs, which obviously is also associated with experiencing overdose and increases the risk of death related to overdose, which is also, as we know, one of the leading causes of pregnancy-associated deaths. And it's not just mental health outcomes or health behaviors that could be considered coping mechanisms that this is linked to, right? Because sometimes people say, well, yeah, if you experience trauma, of course you have more depression, or of course you have more anxiety, or of course maybe you use more substances because you're trying to mask and all the things, right? Those connections are a little more obvious. But it also has this broad impact on general health. So we know that ACEs are also linked to an increased risk of diabetes, of heart disease, of lung disease, even when we control for people who have never smoked, and of cancer. There was even a recent study, well, I guess it's not so recent anymore because what is time since COVID, but that showed that the more ACEs a person had, the more likely they were to decline the COVID vaccine. So this not only has huge personal health implications, but also significant public health implications. So keeping in mind how common ACEs are, it is essentially guaranteed that we are interacting with people all day, every day who have experienced significant adversity and or trauma. Now, this next slide shows some outcomes that are more specific to reproductive and sexual health that are also associated with higher ACE scores. In addition to the items listed here, ACEs are also associated with intimate partner violence, both perpetrating and being the victim of. It's also associated with more pelvic pain and with increased discomfort during pelvic exams. So we've established that ACEs can have long-lasting negative impacts on our health. And one of the proposed mechanisms for that is through toxic stress. Now, of course, we know that not all stress is bad, right? Some stress is healthy and positive. It prepares us to respond to temporary challenges in our lives, like running a race or starting a new job or public speaking to your esteemed colleagues who may or may not know enough about this topic before you started talking, right? So when these stressful events occur, our stress response activates and then quickly returns to baseline, right? Now, more or longer lasting stressors can be tolerable if we have the support systems in our life to help us cope, right? Back to that definition around something that exceeds our ability to cope, right? Now, if we don't have the supports, severe or frequent exposure to certain types of stress can have a toxic effect on the body and the brain. Dr. Nadine Burke-Harris, who is California's first Surgeon General, has a great analogy for when positive or tolerable stress becomes toxic. And I'm going to share that with you today. So I want you to all go on a journey with me for a moment, right? Picture a beautiful day. We've gotten past the brutal part of winter. It's gorgeous out. We are going to take a walk through the woods, right? We're out, we're enjoying nature, and then you see a bear. Your body's going to have a reaction in this moment, right? You're going to release tons of hormones. You're going to release adrenaline and cortisol, and that's going to help you either fight the bear or run from the bear. I'm definitely not going to be successful with either of those strategies. So hopefully my default is freeze, and hopefully that bear is going to leave me alone, right? Some people, of course, add fawn to fight, flight, or freeze. That's obviously a little bit less relevant to the bear, although if it's cute enough, I don't know. But anyway, so of course that's your fight or flight response kicking in, right? And when you have that response and it happens only once in a while, it's a really good thing, right? It's protective. It can save your life. It activates you enough so that you are able to respond appropriately to the bear in that instance, right? Or to put on my heels and come up and speak to you, right? The taller my heels are, the more like insecure I am, right? So that's where we're at, right? So now you've got that response going, it's helping you out. But now for a moment, imagine what happens if that bear follows you home and moves in with you, right? Now you are keyed up all the time. Think about what kind of reaction you have when you wake up every morning and that's what greets you. What happens in your brain when you're faced with that level of stress every single day? Our bodies truly just aren't built to be in fight or flight all the time. So we're going to talk a little bit about what happens in the brain. We're not going to get too detailed, I promise. But we're going to talk about what happens to the brain when that bear is living in your house. So sustained activity or activation of the body's stress response, like in that analogy, physically impacts the brain's function and actually its I want to say design. It's actual like structure and function. There we go. So, a pathway in the brain that secretes hormones gets dysregulated, and the part of the brain that regulates memory and learning actually shrinks, right? The area of the brain that regulates thoughts and emotions shrinks, and the part of the brain that connects emotions to many other brain abilities like memory and learning and our senses gets bigger. The part of the brain that takes in information from experiences and turns that into how we understand the relevance of other future situations and how to respond to that appropriately begins to lose its ability to respond. Now, when you add in those stress hormones of cortisol and adrenaline from that chronically activated fight or flight response, along with all this chronic stress, you get inflammation, which also contributes to all manners of ill health. Now, these brain changes can actually alter the way that a person views the world and the way that they function in the world. How they build or struggle to build trust, for example, which obviously has an impact for us in our work when we are trying to build rapport very quickly and get to some very intimate and challenging topics with people who really are near strangers to us, right? Now, since this can manifest in a lowered ability to regulate behavior or control expression of emotions, we can also imagine that this is going to impact our patient experiences, our client experiences, as well as potentially experiences with our coworkers. So, have you ever had a patient or a coworker who has responded in an unpredictable or unexpected way to either a major event or even a commonplace event, right? Behavior might appear impulsive or out of control. And this is something we really need to keep in mind during our visits or when discussing exposure, that scripts and norms may be completely out the window, right? So think with me, have you ever looked at someone and thought of these 5 words? Have you ever called someone any of these words? The next time that you look at someone and think one of these thoughts, think about what might be going on behind the scenes for them. These changes in the brain also contribute to what people refer to as coping mechanisms. We started to talk about coping mechanisms a little bit earlier. So these are personalized strategies that are really designed to help people function in their daily lives and in the face of past or ongoing trauma. Now, these behaviors may initially appear to be dysfunctional or maladaptive, but ultimately they're perceived by the person who is using them to facilitate survival. It's how they make it through, right? And it's important to remember that people aren't always conscious that these activities are in fact coping mechanisms, right? And you may recognize some of these in folks that you've worked with, or even in your personal circles. So some of these coping mechanisms can be things like self-medicating, like what we might refer to as reclaiming their sexuality, right? I started as a sexual assault nurse, and it's not uncommon for someone who has a history of sexual violence to have a lot of sexual partners or what we might perceive as like sexual acting out. And it's a way for them to say, like, my choice was taken here. So now I'm going to go and kind of control the situation, right? But it may still have health risks. Could be dissociation, self-harm, anger and aggression, things like that. Okay. Now, before we move on and dive into trauma-informed care and what we can do about some of this, I want to take a minute to talk about something called activators. Now, activators are things that remind someone of a prior trauma, or in some instances, can actually initiate a flashback. Now, you might be familiar with these things being called triggers, right? But there's kind of a call to switch from calling it triggers to calling it activators. One, because trigger, frankly, has just become really stigmatized, right? And two, this is one of our first opportunities of the day to really think about our language, and we'll come back to that. But trigger is actually a word that is based on triggering a gun, right? The trigger of a gun. And what an opportunity for us to intentionally move away from a language of violence, right? So subtle changes that may or may not change the world, right? But we can do these little things in our daily lives. So you'll get to hear a handful of my soapboxes. So again, activators can be conscious or subconscious. It can involve any or all of the five senses. We can think it could be a smell. Smell is actually one of the most strongly associated senses to memory, right? It could be a touch in a certain way. It could be a certain word, or even the way that a certain word is spoken, right? So imagine, if you will, a certain cologne that a patient smells in your waiting room, right? Or a song that's playing in the lobby that reminds someone of a past trauma, right? So when someone's activated, they may feel extreme distress that is similar to what they felt at the time of the initial trauma. And their physical reaction may actually mimic a reaction to that initial trauma. So that could be crying, shaking, dissociating, even vomiting without sort of an understood cause. And because of how personal every trauma is and people's individual activators are, um, we may not be able to predict what's going to initiate an activated response, like a flashback, anxiety, panic, or even dissociation. And patients may also be unprepared for or unable to predict the activator. Now, we also have to acknowledge that this can occur not only for our patients, but also for staff and providers. So, we've built this understanding of how common and broad trauma is. We also have to assume that we ourselves and our colleagues have likely experienced ACEs and carry certain traumas with us into our interactions as well. So, one of our biggest and hardest jobs as providers and as people who work with the public in what is often a stressful environment is to figure out how to remain regulated in the face of someone who is dysregulated, and to figure out how to calm ourselves again when we are faced with an activator in our own work environment. So now that we have this foundation for what trauma is and what negative impacts trauma can have in a person's life, including how they perceive and interact with other people, we're going to review what we can do about it. We're going to dive into trauma-informed care. And before I go on, I just want to check in again. Is everyone okay? Any questions before we go further? Awesome. Okay. So trauma-informed care is a whole person approach to healthcare that acknowledges the impact of trauma on health and that is inherently patient-centered. Now, SAMHSA describes the trauma-informed approach through the 4 Rs, which are here on the slide. So a trauma-informed approach is one that realizes the widespread impact of trauma and understands potential paths to recovery. It recognizes the signs and symptoms of trauma. It responds by fully integrating that knowledge about trauma into policies, procedures, and practices. And it seeks to actively resist re-traumatization. And I would also argue that within health services, it's also seeking to resist the creation of new trauma, right? So ideally, this is going to guide the tone and process of our care at both the individual and organizational level. Now, A trauma-informed framework assumes that everyone has a trauma history and that medical evaluations and treatments themselves are potentially traumatizing. Probably with your work in the field, you can understand that easily. It also acknowledges that patients' life experiences will impact their perspectives and priorities when they're engaging in the healthcare system, and that awareness of the perspectives has the potential to improve patient engagement, treatment adherence, and health outcomes. Now, we're going to play a quick 3-minute video that is a great introduction to trauma-informed care. It also talks a little bit about ACEs, so you'll get kind of a, this is the secret, like you got to hear things a couple times for it to sink in. So, it's also going to do a brief overview of things that we can do to implement a trauma-informed approach to care, and then we'll do more on that in a sec. And also what the video does is introduces what I really think is the greatest take-home message of this whole talk. So if you only take one thing away today, it is this, which is that at its core, trauma-informed care is a paradigm shift, a moving from looking at someone and saying, what is wrong with you, to looking at them and saying, what happened to you? Meaning we move from a place of judgment and frustration to one of curiosity and empathy.
You know the old saying, don't judge a book by its cover? Well, the same is true when you assess a patient. Hi, I'm Dr. Cruz. Early in my career, I noticed a pattern with some of my patients. They often had multiple health issues, were uneasy during office visits, and frequently visited the emergency department. But worst of all, they never got better despite multiple visits. Then I realized something. From an early age, many of my patients were exposed to trauma and adverse childhood experiences, or ACEs. This includes emotional, sexual, or physical abuse, violence, neglect, discrimination, poverty, and other adverse events. ACEs are more common in the US than you'd think. In fact, 60% of US adults have one ACE, 25% have 3 or more ACEs, and 16% have 4 or more. ACEs occur in all socioeconomic groups, but are more common in low-income and minority populations. For young children, repeated exposure to trauma can impact brain development and literally rewire the brain's response to stress. So as they grow up, many struggle with issues related to emotional regulation, like depression, anxiety, or substance use disorders. Trauma survivors are also more often at risk for chronic diseases, behavioral health problems, and even suicide. Knowing all this, I began to rethink my approach to care. Instead of asking patients, "What's wrong with you?" I ask, "What happened to you?" Recognizing that life experiences are often a root cause of poor health is integral to improving patient care. Trauma-informed care has helped me take these experiences into account, providing greater insight into my patients' needs and how to address them. Here are 5 key ways that healthcare organizations can gradually integrate trauma-informed care into their practices to help patients and staff. First, build awareness and generate buy-in. Involve both staff and patients in adopting a trauma-informed approach. Second, invest in a trauma-informed workforce. Hire staff that embrace trauma-informed care and provide training not only for clinical staff, but also for non-clinical employees like front desk workers or security guards, who are often the face of your organization. Next, create an environment that is safe and welcoming for patients and staff. Engage patients in meaningful ways. Ask how they feel and listen. You can also build trust by involving them in their own treatment planning. Finally, identify and treat trauma. Consider a screening approach that works for your patients and ensure that treatments and referral sources are available. These changes take time, but each step improves our ability to connect with and care for patients. Today, our patients appreciate the changes we've made. Plus, our staff is more in tune with patients, so work is less stressful and more rewarding. Trauma-informed care. It can truly transform the caregiving experience from being treaters to being healers.
Thank you. All right. Awesome. So we're going to go back a little bit and think now, what does this actually mean, right? Because trauma-informed care is really easy to talk about as an academic concept, which again, I really love to do. But if we can't operationalize it, then it's not really helping anyone. So again, at its most fundamental, it's that paradigm shift. If there's that one thing to take away, it's not what's wrong with you, but what happened to you. I feel like this is a really powerful shift for everyone, but especially in some of those really trying times, right? Um, so, trauma-informed care is not the same as providing medical trauma services like treating a broken leg or intensive therapy for trauma. Rather, the foundation of trauma-informed care is the assumption that all people carry past traumas and that all people will benefit from this type of approach. And importantly, disclosure of past trauma is not necessary to use trauma-informed care. Okay. Um, this is called using the universal precautions approach, sort of like donning gloves, right? In healthcare, we don't wait for labs to come back, right? We don't need to find out if someone has, a bloodborne illness. We just put on our gloves for everyone, right? And we can do that with trauma-informed care, so that it becomes so much a part of us that we don't even think about it consciously. We just put on our gloves. It protects our patients and it protects us. And using this trauma-informed approach model with that same universal precautions model just assumes that everyone that we interact with is likely to have experienced something difficult and can benefit from these strategies. So again, this approach is not just for special populations, right? So maybe those that have a sexual assault history, or a patient that is living unhoused, or someone coming in for a first pelvic exam. Everyone will benefit from this type of approach. And again, no one owes us a disclosure. Now, it's of course true that the more I know about my patients, the better I can help them, right? It is not owed to me. And in some circumstances, it might not even be relevant, right? Or just may not be somewhere they want to go today, right? It's different if I'm seeing a patient who has been a long-term patient and I've been their provider for years and we've built trust and relationship and we've weathered challenges together, versus someone who's just seeing me in clinic who really thinks they have a yeast infection and all they want is to get their itching to stop, right? They probably don't want to give me their whole history, and that is okay, right? And in some of the models that y'all are working in, you may also be likely to be that singular point of contact for someone. You may not be building a long-term relationship, right? Patients can seek focused care and not want to share their full stories, and that really is their right. So again, every single human will benefit from this type of approach. And again, it's true not only for our patients, but also for our colleagues and coworkers. And my next soapbox, also for our loved ones and community members. Can you imagine the society that we would be able to build if everyone moved through the world with this type of mindset, right? So finally, of course, this includes you as well. So remembering that providers bring their own trauma histories into encounters. In addition to that, we also know that interacting with empathy with other people's stories of trauma impacts us as caregivers, right? And this is called secondary or vicarious trauma. And it can have physical impacts on us, very similar to like PTSD reactions, or it can also change our worldview and brains in ways that are similar to how primary trauma affects the individual. So again, I love to talk about vicarious trauma. So if you have questions or want to talk on that more, come find me during our snacky schmoozy hour and we'll talk about it. Okay, cool. Sorry, I'm behind on my clicks because I know that Jen is doing such a good job. Okay, awesome. All right, next slide. So we've talked about the 4 R's, and now we're going to move on to talk about the 6 key principles, okay? So these are some ways that you can start to enact a trauma-informed approach in your work environment. So the first principle is safety. So we know that after a traumatic experience, safety can be difficult to be regained for people. Now, in practice, both physical and psychological safety both have to be considered, and that really has to be throughout an organization. And that is safety both for staff and for the people that they serve. Now, for emotional safety, we want, of course, to give our patients or clients power and control whenever possible. We want to listen. We want to not interrupt. We want to be fully present. We want to pay attention to nonverbal cues. We want to be patient and avoid invasive questions. Now, I know that saying avoid invasive questions when we're talking about STI and HIV or any kind of sexual and reproductive health is a little bit of an oxymoron, right? Like by its nature, that's what we're doing is invasive questions, right? But the reframe for that, I think, is to make sure that we're only asking questions that serve a purpose. Right. So, if you have the ability to skip a section on your forms that is not relevant or whatever else, think about that. Right. And I know, I don't know how many of y'all are using like an EHR where you're like click bound. And if you don't click a box, it won't move forward. Right. And that's a challenge here. But anytime that you can think about, does what I'm doing serve a purpose? Will it impact the outcome? Right. Those are questions we have to ask. Right. Let's move on to talk about physical safety. Now, we want to consider the environment from even before someone enters your space. Is your parking lot well lit? Or might someone be coming in already stressed from a walk through a dark or uncomfortable outdoor space, right? It's also important to remember that safety can be defined really differently for different people. One kind of clear example of that is the presence of an armed security guard. So for one person, this might make them feel really secure and protected, right? But for another, it could feel threatening depending on their personal or community experience with policing, right? People's experience will always impact the way that they interpret what's around them. Now, I also want to acknowledge that do some of you do home visits? Yes. Okay. So that brings all sorts of different safety considerations to the mix, right? For patients, we know that there is a whole different level of vulnerability inherent in having someone come into your own personal space, right? And also, your safety counts too. So, what do you need to feel safe going into someone else's environment where you don't have a full team or really control in the same way over the situation? How does your program or supervisor support practices that promote your safety and comfort? If this isn't a conversation that y'all have had, it may be worth having. So, again, whatever our practice environment, we need to consider safety for staff and the people we serve. Next, we look at trust and transparency. Now, practicing a trauma informed approach means that decisions are conducted with transparency. The goal is always building and maintaining trust with clients. During your interview or during discussion, again, you can practice this by discussing in advance what information you're going to review with them. You can also let them know why you'll be collecting certain sensitive information before you ask them. So, those questions that have a purpose, remember that the people you're talking to may not know what that purpose is, right? And it is very different if you're explaining, hey, I'm going to ask you about your types of sexual activity because it's going to help us know where we need to test, right? Versus just saying, like, tell me what kind of sex you're having, right? Which I assume is not how anyone's approaching it. But imagine the way it sits when we just say, like, do you have oral, anal, or vaginal sex? Versus, I'm about to ask about your sexual practices, and here's why, right? It hits very, very differently when we're transparent. So, we want to do the same thing with why a particular procedure might be recommended, right? Just to be upfront about why you're asking or why you're recommending things that may be difficult for patients. The next one is peer support. And this is really valuable to helping people build safety and hope. Peers are those who have also survived trauma. So we often think about this in terms of support groups for something like infant loss or infertility or in public health, we can think about peer counseling and substance use or substance use treatment and HIV care. This really is people using their own stories and their own journey and questions and lived experience to help promote healing together. Okay. It also matters for your teams, right? Knowing again that we may be working in environments that increase our stress and that can have trauma in them. We want to make sure that we are supporting our teams because between HIPAA and all the other things, like we know that we can't talk normally about the things we do every day out in public, right? You often are the only people that you can talk with about the work we do. So also for your teams. Next is collaboration. Now, a trauma-informed approach places importance on developing a partnership between staff and those they work with. So a main goal we talk about is leveling power differences between you and the people that you care for. We have to acknowledge that there are inherent power differentials just baked into what we do, right? They don't call it white coat syndrome for nothing, right? Patients come in needing something from us, right? We are often serving as gatekeepers, and our titles and our roles and our formal education, all of these things comes with power, right? And we need to acknowledge and honor that no matter our expertise or our role, our patients are the experts on their own bodies, on their past experiences, on their current experiences and preferences, and on their priorities and goals. So we need to validate their priorities and concerns. We need to set goals and plans with them and not for them. Some people call this shared decision making, but it may actually be better to frame it as patient-led decision making. Moving on to empowerment. This is really enacted when we focus on the strengths of the individuals, right? And the experiences that they have that can be recognized and built on. So it calls on us to really believe in the resilience of people that we serve and the ability of individuals and communities to heal and promote recovery from trauma, right? So again, supporting shared decision-making helps with this, mutual goal setting, choices, all of these things help with empowerment. We also want to make sure that we're framing things in a positive and affirming way, right? So rather than, why did you let that prescription lapse? Right? Or, wow, you're coming in really late for treatment or for prenatal care or whatever the case may be. Instead, trying, I'm so glad you came in today and let's work together to get back on track. Right? How different does that land? Right? The last principle is around people's context in the world. And this includes recognizing places where historical trauma may play into mistrust of healthcare or medications. Working on identifying and working through any personal held biases. A good example of this, I think, is who should or should not become pregnant. Do you have any personally held feelings around that, right? Because it's really our job to work through that on our own, not in front of a patient. Right. Another could be, are there types of people who are more likely to need multi-site testing or PrEP or anything like that, right? What kind of biases do you come in with? And I assume that y'all have done a good amount of work on all of that already, but it's important to acknowledge that, especially for folks who are kind of newer in the work. We, of course, want to offer gender responsive services, use humility, and always work on knowing more and doing better. So next, we sort of started to explore this as we discussed. If you do one more quick click, Jen, thank you. Awesome. All right. As we discussed the 6 principles, but here's a couple of other examples of subtle changes in language that can actually make a really big difference. Again, you've already heard my soapbox about how the language that we use can really shape how we approach the world. So I also love this slide because one of the concerns that I hear from people about implementing trauma-informed care is that it's going to take a lot of time and what is often rushed visits and too busy schedules already. And I think that this really shows that these changes can be really small and don't have to take a lot of time, right? So think a little bit as you leave today. About what are some of the language within your own practice environments that could shift to really impact the trauma-informed tone of the care that you provide, right? And you'll see so much of this is about asking consent and putting the power back in their hands, right? I think about with pelvic exams, I really like the last one. You know, when I started my training, people were talking about, making sure that you told someone before you started the pelvic exam. Like, can you imagine can you imagine just like touching someone without telling them, right? It's baked in, I think, for us to at least say, you're going to feel me touch, right? Like we at least are giving a warning. But how much better is it if we say, let me know when you're ready to begin, right? Really subtle touch. They're likely to say, I'm ready, right? And if they're not, they're going to let you know something really important, right? So subtle change makes a world of difference. Okay. So let's talk a little more specifically about TIC in the HIV and STI world. You've seen this slide before, but again, I just want to come back to it and acknowledge a little more deeply something that I started to touch on before. We know, and it's okay to acknowledge that often patients dealing with trauma can be perceived as difficult clients, right? Maybe it's frequent flyers, where we know that some of our best efforts to support and help and guide just seem to fall short. And it is okay that it is natural for that to feel frustrating, right? When you feel like you have gone above and beyond with time and giving of yourself, and then you turn around and they didn't follow your good advice, right? Or they put themselves back in that same position, or whatever the case may be. These really are those moments to pick up on that in yourself and focus on practicing that paradigm shift. Not what's wrong with you, but what happened to you. Okay. So, we're going to spend a little bit of time now thinking about what it feels like to be a patient. Um, so, what does our patient or client feel like before they come to the office, before they meet their provider? Well, they're in your waiting room waiting to be called back for an appointment or examined. How many times have you gone to an appointment and wondered some of these things? Did you know, I mentioned earlier about not interrupting? Did you know that there's a study that shows that on average, it takes 11 seconds for a provider to interrupt a patient? That's really not very long, friends, right? And it's not because we don't care. It's often because, again, we're working in rushed environments. And a lot of times we sort of think, oh, I kind of know where this visit is going, so I'm going to direct it in this way. But I don't remember what the number is, but they looked in this study at how long patients talked if they weren't interrupted, and it's not grossly longer. And it makes a huge impact on the patient's experience of the visit to feel listened to, right? So, something to be very aware of. Okay, so what can be done to alleviate these fears and concerns that the people we're caring for have? Well, there's so many things that can be done. So we know that a clinical experience starts where the patient walks into your physical space, right? The entire clinic should ideally practice trauma-informed care top to bottom, right? So we want it to continue then throughout the visit with every single person with whom they interact. And there's a lot that they interact with, right? Um, Even after the visit, we can think about how to be trauma informed when we think about kind of what information is provided to them and how when the visit is ending and what their understanding of the care plan may be. So let's dive into the details of all of that a little bit. Now, if you work in an office setting, what does your wait? And I know some of you don't. So gosh, I hope this feels relevant to most of you. But what does your waiting room look like? Is it cramped? Is there music playing? Are there any visually pleasant pictures or paintings? And then, of course, we have our front office staff, right, who represent the entire practice at every level. How do they interact with the patient or the client? Do they act neutral and like they're just there trying to check boxes and get through their day? Or do they see the person in front of them? Do they smile? Are they welcoming? What do they actually say to the patient? Do they reveal personal information about the patient in front of everyone in the waiting room, right? And we know sometimes our physical plant is not ideal, right? Sometimes it's very hard. But I remember one clinic I was working where people were just like straight up asking, like, "Can you tell me your social security number?" at the desk, right? And they didn't have they felt like they didn't have a way around it. So we ended up asking people to write it down, right? And it was like weird and not ideal, but was the best that we could do. Okay. So look at these pictures. Check out that first one, and then look at this one. You see that difference? Like you can actually feel that difference, right? So one of these could set a patient up for a great and affirming visit, or a really negative experience with kind of your care and the whole process, even if you yourself are super awesome, right? So you want to really think about all of the details. Do you have any signage that's welcoming at your front desk? So if you look at that little graphic in the corner, it's hard to read, so we're going to enlarge it. And this graphic underscores a team approach to healthcare, that the patient is the most important person in this visit and that their voice matters. Having these simple things around kind of when someone enters sets the stage that this can be a safe and supportive place. And actually, this is available for free in multiple languages through the HCET website. So you can grab it from us anytime. So it's in Spanish and Haitian Creole as well as English. Okay, so let's talk about what happens after the waiting room. Now, often a medical assistant or a nurse is going to call the patient back from the waiting room and get their vitals. How do we call the patient? Once they walk in, does the MA introduce themselves? This, friends, is a huge pet peeve of mine. It is the next soapbox I am on. It's such a basic way to show kindness, right? It's connection. It's seeing someone as human, right? We, of course, are bringing back dozens of patients a day, but like, tell me your name, right? You're going to know plenty about me, right? Is there any small talk? How have you been today? Or are you just kind of walking through with awkward silence when they are likely anxious already? Now, while the patient's in the waiting room, what are they looking at, right? Or excuse me, not the waiting room, in the exam room. So this next image are actually light covers that a colleague of mine worked to have placed in all her exam rooms, right? It's just a little something to distract. And in truth, we know that distraction is actually a really great way to help with pain relief, right? There's real studies about that, right? And visual distraction can be really helpful when trying to not focus on parts of the exam or other things, right? Another fantastic distraction can be music. And I know that I just also reminded you that like music can also be an activator, right? So there's that kind of delicate line. You could consider letting a patient choose their own music. You could consider a sound machine with neutral noise, all these different things, right? You know your environment and what's going to work, but all these different things to think about. We can also encourage a patient to listen to their own music out loud on their phone, right? Everyone has their own, like, right, all the things. I was about to date myself in how I phrased that, so I'm just going to leave that there. Anyway, also, I want to quickly jump to the end of the visit. We know that no matter how well we communicated, it isn't always received, right? And we know, remember when we talked about the brain and how kind of trauma and stress can change the way that we're taking in and making memory and processing information, right? No matter how good we are, people often aren't receiving what we're seeing. So providing written information, if you can, is so valuable. I'll leave that there. Okay, cool. So we're going to talk a little bit about the pelvic exam next, which again, I'm not sure how many of you are involved in or the people that you're seeing or have a potential for this, but we'll talk about it quickly. We're pretty good on time, right? We got till 5:15? Oh, just till 5. Oh, we'll talk so much faster. Okay, ready? Here we go. Okay. So then let me ask, how many people do have pelvic exams happening in their environments? Okay, great. A handful. We'll do it. Okay, cool. So you'll note the word choice up there, right? Footrest versus stirrup, drape versus sheet. I'll mention that one's newer for me, right? So we all keep learning. A big one is exam table, not bed. We are striving to take sexualized language out of the clinical environment, right? Because the honest truth is that what we do in our clinical care mimics what happens in people's intimate relationships, right? And intimate encounters, whether consensual or not consensual, right? That's just the truth. It makes me so uncomfortable to use the language of intimate exams, right? Because I don't want to think of anything that I'm doing with a patient as intimate. But that's actually showing up in the literature more and more and more, because the truth is that that is what it is, right? It is very intimate care. Um, so we have to acknowledge that, again, the clinician is in a position of power. There may also be feelings of medical necessity rather than options or opportunities to decline. So even if we're giving someone an opportunity to decline a piece of care, is there really that option? Like if the test or exam needs to be done, right? Now, we now have a lot more options for things like self-swab and things like that. But like, even with that, there are still times where we need something to be looked at, right? And if you want to find out what's going on, it's not really something you can decline and get a full answer, right? So even if we're saying, oh, you follow me. Okay. We also have to acknowledge that we are near strangers and that no one is at their best when they are naked, right? Most of us are not our most comfortable or our most empowered. Some of us are, and that's awesome, but most of us are not, right? And again, adding to those power dynamics and all of the things. Okay. Oh yeah. And not to mention, not just naked, we're like fully genital exposed, right? Like no one's loving that. Okay. Next, of course, the exam itself. Well, it shouldn't be painful. It's certainly not the most comfortable sensation in the world. And we know that for a percentage of our patients that experience genital pain disorders and other things, there will be significant discomfort. So, okay. Again, we cannot ignore the intimacy of our work. Stuff that is normal for us that we may do dozens of times a day is anything but normal for the people that we serve. And we have to remember that. We have to remember that this may be a situation they never saw themselves in. And we have to step back and remember that, again, while we're doing this over and over and over, and going faster makes us more likely to get a chance to eat lunch or to clock out on time and all of these things, that these are often big life moments for our patients, and we can't rush it. Okay. Now, we also have to acknowledge that there's some people for whom this is not a big deal at all, right? So we also don't want to sit there and be like, I know that this is like a big and scary exam for you, right? So again, remembering experience is key. And that's part of why one of the things that I'm sure makes you all special and good at your jobs is the way that you can like vibe off of humans and understand, right? But sometimes that requires significant communication, and it definitely requires us being present in the moment and really aware and not just like speeding through our days, which again, like is natural, but we really need to work on. Okay, so we're taking our cues from them. We're delivering information with kindness, with expertise and accuracy. Activators, I normally would ask you to come up with this, but for the sake of time, think about some of the things that are kind of like yucky that can happen in exams. Things like telling someone to just relax or open your legs wide. We're going to work on never saying things like that, right? Other activators is just having someone standing over someone while they're in the supine position. That's very powerless. Again, never pushing someone's legs open, thinking about how you can explain sort of how you need them positioned to do what you need to do, that never involves that. So it could be, hey, bring your knees out to meet my hands. It could be explaining like, think about a frog position. It could be think about letting your knees fall out to the side like you're doing yoga, right? You can think about what verbal cues you'll use. But you really want to think about all of that and not pushing people into decisions, etc. Okay. Oh my God. Okay, time. All right. I think we'll sort of skip through the seeking healthcare immediately after trauma. No, I won't. Okay, I'll just say it quick. So there is something that happens when seeking trauma immediately after, seeking healthcare immediately after trauma, and the way that the brain links them together that can impact people's ability to seek care throughout their lives. Okay. So we often think about this in the context, again, of a medical forensic exam or going to the ER after a car crash or things like that. But we have to think about that a lot of the things we do also can be traumatic for folks. So exposure to an STI, diagnosis of HIV, learning of an infidelity, maybe learning about an undesired pregnancy. There are any number of reproductive and sexual health scenarios that can be traumatic as well. So we want to give, again, the patient as much power, choice, and control as possible. So again, do they want testing from urine or a self-swab, or do they want an exam? Sometimes I think we think we're being kind by offering a self-swab and having them decline an exam. And gosh, doesn't that help our schedule move faster? But the truth is, sometimes people really want to be seen and reassured that they look normal. So again, offering the range of choices. Is the exam an opportunity to educate and promote healing, right? Can we reassure them of their normalcy or the fact that they look healthy, right? If that's within your role to do. And is an exam necessary for the presenting concern? Are we ever just going through the motions without kind of thinking through what we need to do? Could it be deferred? Could it be performed doing a different position, right? Instead of using the footrests, could we use the like table, the edge of the table, right? That's actually fun because then you can set your supplies on it too, right? It can help you also, but there's lots of different positions we could use that we don't necessarily think of and options. We also, of course, can talk to patients about placing the speculum themselves. Okay. Cool. Similarly, expedited partner therapy, we need to think about, do they understand, is that an option, right? How are we going to talk about that? We want to make sure that our patients understand what is being tested for and what isn't. How many times have you had someone come in who says, oh, I know I'm good, or I know that my partner's good. They were tested for everything, right? Okay. And I think people really think that, and they have no idea. And you say, oh, okay, so you had blood drawn? And they're like, oh, no. And you're like, oh, okay, cool. Right. So that's actually on us. That's us not doing our jobs of educating people. Right. We also want to make sure that they understand window periods. Right. How often have I had someone come in and say, I had something happen this weekend and it's Monday and they're coming and asking for testing? And we can absolutely do baseline testing, but I really need them to understand what that's showing and what that isn't, right? Okay, cool. Now we're gonna do a quick deeper dive into informed consent. So what is consent? Again, normally I'd make y'all come up with it, but I'm just gonna throw it up there for the sake of time. Let me back up. I'm not going to stress out about questions, friends, because we're going to chat during the hors d'oeuvres. Okay. So we're going to do it and then we'll see what happens. Okay. Jen, if you would pop that list up there. Consent is unmistakable, often verbal. It is uncoerced. It's freely given. It is reversible. It is specific, and it is informed. There is a nurse midwife named Stephanie Tillman who says, consent is a clear dialogue between individuals to engage in a specific activity. Expectations for consent to intimate examinations in healthcare should be equal to, if not exceed, expectations for intimate interactions in society. I find that incredibly powerful. Additionally, the absence of a no is not a yes, right? When we think about consent in a medical environment, of course, we often think about forms, but let's be honest, no one is reading those forms, right? One thing that I always want to touch on here when we go back to the ways that our exams and care are closely linked sometimes to people's intimate experiences. Think about this scenario. How often, don't answer how often. Can you picture a scenario where we are in the middle of doing a pap smear or placing an IUD, right? And a patient says, oh, wait, stop. And the clinician says, just a sec, I'm almost done. What's the other scenario where we talk about consent? It's often medicine and it's sex. And if someone was in a sexual encounter and a partner said, wait, stop. And the response was, just a sec, I'm almost done, right? We all understand how unacceptable that would be assault, period, right? But it's common in a healthcare setting. And again, I don't think that's because anyone intends to cause harm. I think it's because we think to ourselves, this is the service they came for, right? And maybe they really want the IUD as their method. And if I just had 3 more seconds, it would be in, right? And they've already been through the tenaculum. And so let's just do it. But that requires a better conversation. One of the strategies I like to use is talking about, I often will say, like, you can tell me stop or you can tell me pause, right? And if you say, or sometimes I'll just stop and out, because stop is actually a pretty knee-jerk reaction to say, right? And so I'll say, like, if you say stop, I will stop what I am doing completely. And we will check in. And if you have questions or just need a moment to breathe or whatever it is, great. If you say out, I will take this back. We will be done. Like, no questions asked, we will be done. But I also want you to know up front that that means, like, it is possible that we will not complete the service that you came here for, right? Because I think that's our fear when we say just a sec, right? But then the power is in their hands. We are never going to continue on past that stop without checking in, without their permission to continue, right? But if they say out, they know we're done now, right? And people sometimes will asking for a verbal cue can be difficult. So if that's going to be difficult, it can also be a physical cue, whatever you want. But I think that's an important thing, both for us to feel comfortable that we're delivering the care that we're trying to deliver, and also that they are in control. And we are never going to do that just a sec, I'm almost done, which we know crosses a line after someone has told us no or to stop. Okay. I actually covered a lot of this in that last rant. So we know that, again, unintentional misunderstandings can happen for, oh, sorry, if we can do the next slide, can happen for 1,000 reasons. Oh, did we miss this slide? There we go. Great. Yay. Okay. For 1,000 reasons, including, again, that what's routine to us is anything but for them. Also, we've talked about that trauma brain. We've also talked about, or we haven't talked about, but another one is like biological needs. If someone is hungry or tired, or they're worried because they've waited so long in your office that they're worried about getting home to their kids or pets or work, right? There's all these reasons that miscommunication can occur. We know that things can be perceived as assault if the patient does not believe that they've given consent and given consent freely. We've talked about context. We've talked about power dynamics. Really important to remember that a true informed consent process allows for a yes as well as a no. Informed declination is as important as informed consent, and you can document that, right? Patient educated on options, on risks, benefits, and chooses to not receive X, Y, or Z today, right? That's okay. And again, it's their choice, not ours. Okay. The note about language, for my last soapbox on that, is just think about the difference between the word decline and refuse, right? What does it imply when we say someone refused a service versus someone declined? Where is the agency in what we're saying? Okay, next slide. Now we're on wrap-ups. So we always want to explain the steps and equipment before everything we do. We want to think about the place and space for positioning and comfort, right? What can we do to make things better and more comfortable? Again, we cannot assume a right to other people's stories or their bodies. They don't owe us a disclosure. They don't owe us an exam, right? Thinking about asking permission. With your permission, I'll begin the exam now, right? Let me know when you're ready to begin that exam. We want to be focused on empowerment and reassurance when we can. Remember that there's so much shame often in the behavior that brought them to you or you to them, right? But what we're actually often talking about is now people taking really good care of themselves. So again, what language can we use that is powerful? I also think about the sexual risk conundrum, right? That we take risks every single day for things that we love. Whether it's that we drove 6 hours to get to you yesterday, right? There are risks in that. Whether it's riding a bike, going skydiving, whatever thing you're into, right? And we do things to reduce our risks. We wore seatbelts yesterday. We drove the speed limit. You put on a helmet for your bike, whatever. But if you fall off and skin your knee, no one's blaming you, right? You don't feel ashamed of that. And yet when it's risks for sexual behavior, which by the way is often something we also love and enjoy and brings us pleasure, just like that bike ride, right? But there's so much shame involved. So think about how we can really build them up as they take good care of themselves now. Preferences for communication. Again, some people want all the information and some people are like, I don't really want you to explain all of this to me. Like hearing about that is yucky. Can I just get on my phone or put my headphones on? It used to really offend me when patients were on their phones. If that's their coping skill, cool, right? What's the minimum you need to communicate for it to be okay? Awesome. All right. Also thinking about, you can also, of course, think about that during things like a blood draw, right? Do they want to know every step or do they prefer that you distract them by talking about the weather or their pets, right? Or that you stay quiet and let them do their own breathing or whatever calming regulation they want to do. If you don't ask, you won't know. Okay. Also, of course, thinking about with blood draws, that there is a link for folks often, not always, who have experienced sexual assault and the act of having blood drawn, right? It is something perhaps unwanted or perhaps painful that is entering their body, right? So that actually can be an activator that we don't always think of the same way we think of a speculum exam. And of course, you're aware of the potential activator around folks with IV drug use history. And then trust, remembering that we discussed trust as a specific cognitive schema that's impacted by trauma. So we have to keep that in mind when we approach people and build relationship. And above all, we're going to trust that our patients are the experts in their own lives, even though we are the experts in the medicine or STIs or whatever it is, right? That they are the experts in their own stuff. Next one, Jen, if you just want to pop all those up there, we've really talked about all of these universal precautions that shift. The verbiage or rehearsed script is one of those ways that you can help get yourself through a moment where you are feeling activated, right? Just to have something that you can fall back on as a phrase. Again, that you want to explain all recommended interventions and why. Choices. Do you need a pause is so empowering, right? You want to do work on your own understanding of your own traumas and activators, and find a way to prepare yourself for when you are activated at work or at home. And then, of course, consenting your patient in everything that you do, never assuming consent. All right. And we did it. There's references. Yay, 502. Thanks for bearing with me. Woohoo. Okay. Hold that up there for a second. Yay. Yay. Thank you. Okay. So here is that QR code. If you want to hear about more MTITC things, I would love that. You also, again, just through HCET's website, if you click on MTITC, all of our resources are available. There's video resources. There's, again, those patient-facing handouts, and we're making patient-facing materials more all the time. And then, of course, again, my contact information. I'm always delighted to talk to you. Thank you all so much. Yay.